So inflammation is good during an acute illness.
Yeah, absolutely.
Or an acute illness. So
it's essential.
If I twist my ankle, I'm going to get heat, pain, redness, swelling, loss of function.
Yeah.
Which is, taught that a few times.
Yeah.
Which is part of the necessary healing response. The blood vessels will dilate, the nutrients will come out. Yeah. And we know this is essential because if we give people high doses of hydrocortisone or dexamethasone, and we switch this inflammatory response off, then the ankles won't get better. And worse than that, they'll probably get pneumonia and die. Because we need this inflammatory response. But then once we've had it, we need to go from the inflammatory phase, done and dusted, thank you very much, got rid of the bugs. Then we need to go on to the healing, regenerative phase.
Yeah, absolutely. That's
and to do that switch, if we haven't got the vitamin D to switch off the pro-inflammatory stage, then the inflammation can kill us.
Yes. What's often called autoimmune disease is inflammation that's not been switched off. Chronic inflammation, low-grade inflammation, it's not being switched off. And you often find vitamin D deficiency is at the basis of that. And of course, then you get tumours. Tumours have been called wounds that do not heal. Chronic inflammation leads to cancers. The inflammation is not being switched off, and then you get a transformation into cancer. And you find chronic inflammation in the skin, in the uterine cervix, in the esophagus, in the pancreas, in the gallbladder, in the colon, in the breast. I'm sure I've not gone through them all. All these areas of chronic inflammation that lead into cancer.
So it's quite reasonable to say that optimising vitamin D levels could well reduce the chances of pretty well all forms of cancer.
Yeah, and perhaps not all, but most.
Most,
yeah certainly.
I mean, the first research I read was colon. You were a gastroenterologist, of course. So the first research I read was colon cancer.
Yes.
Well, when did you first learn about that, the link between vitamin D deficiency and colon cancer, do you think?
Which when I first learned about vitamin D, basically.
Right, so about late 80s.
About 1990, yeah.
Yeah.
Or the late 80s, yes,
so that's
indeed.
35 years ago, 34 years ago, 37 years ago, and still it hasn't been implemented.
Yeah, that's right.
How long does it take for science to transpose into these bodies, getting their act together and updating their guidelines? It really just...
You mentioned about the calcification in the arteries. Well, it took a long time. I'm not sure it's even appreciated now that the arterial atherosclerosis is an inflammatory condition. It was first noted by Virchow in the late 19th century.
Famous German pathologist.
He described TAMs, tumour-associated macrophages.
He was a clever guy, wasn't he?
Brilliant. And everyone forgot about that.
Yeah.
And everybody thought it was all about cholesterol.
Yeah.
Well, it's not, Cholesterol is there. Cholesterol is part of the defensive mechanism for inflammation. It's in the muscle cells of the arteries that the disease occurs. We don't get arteriosclerosis in veins. There's no muscle layer. We do in arteries. Fundamental difference. And it's chronic inflammation within the arteries that's causing the damage. And we can switch that off with vitamin D in a good dose. And we've got to get that good dose. No good giving people a silly little dose of vitamin D. We've got to achieve the target level.
Traditional cattle herders like the Maasai, other groups in Africa, Karamojong, that live in their kind of natural environment, they've got very, very dark skin, but they're outside all day, every day, under the tropical sun. And their levels of vitamin D in that, what you could say is a completely natural human environment, is well over the 100 nanograms per, nanomoles per litre. Well over the 100, sort of the 150, 160 kind of range, which suggests to me that...
And that seems to be the optimal level, around about 150 nanomoles per litre. But it doesn't go higher, and people do not get vitamin D excess from the sun. And it's considered that any excess vitamin D in the blood is inactivated by the sun. The sun has a controlling effect both on the production of vitamin D and on the blood level of vitamin D.
So that means if I took a lot of vitamin D supplement but was out in the sun,
Yeah.
my levels probably wouldn't go too high. But if I took a lot of vitamin D supplement and lived indoors,
Yeah.
there is the potential
Yeah.
for overdose. Now, you've been a doctor for a long time. Have you ever seen a case of vitamin D hypervitaminosis?
No.
Neither have I.
It is staggeringly rare.
Yeah.
And is always due to either stupidity or mixing up the dose, micrograms, milligrams.
But okay, which is 1,000 times different. Suppose you were in a really bad mood and you wanted to give me too much vitamin D.
Yeah.
So it caused high blood calcium, hypercalcemia.
Yeah.
How much would you have to give me, probably, in terms of probability?
Probably over 100,000 units a day.
For?
Yeah. And also with calcium.
For days and weeks?
With calcium. If you're taking vitamin D, you shouldn't be taking calcium. If you're taking a higher dose of vitamin D, don't take calcium. Because that can lead to problems. We don't need calcium. We're not short of calcium. There's plenty of calcium in the diet, but we need vitamin D to absorb calcium from our food.
Mm-hmm. If you take K1, the bacteria in our colons are going to produce vitamin K2 for us.
Yeah. It's a new thing which I don't know an awful lot about, to be quite honest. The idea is that the K2 prevents the calcium being deposited in the tissues. Well, calcium is deposited in the tissues where there is chronic inflammation, and it's not very common actually either. You know, we
see occasional drain pipe arteries, don't we? Where
we do
indeed
indeed
see the calcium in there.
That's because the arterial disease is due to chronic inflammation. The chronic inflammation is there because the people are vitamin D deficient. Yeah. You don't get the chronic inflammations when you've got plenty of vitamin D on board. Vitamin
D is an inflammatory modulator.
It absolutely, it does. See, when we get an acute infection, we had a body response which is actually orchestrated by something called TNF-alpha, tumor necrosis factor alpha. That's orchestrating this acute response.
It's a pro-inflammatory.
Absolutely, yeah.
Cytokine.
But that has to be switched off. Do you remember the cytokine storm in COVID? That was TNF-alpha produced, modulated.
Too much of it.
And what it has to be done, it has to be switched off. And it's called the macrophage balance hypothesis. The macrophages, white cells in the tissues in particular, are producing TNF-alpha, and it has to be switched off to produce something called TGF-beta, transforming growth factor beta.
Which is a damper downer.
It's a healing one. It damps it down. It's part of the specific targeted defensive immunity then. So we're going from TNF-alpha to TGF-beta, and that transformation is modulated by vitamin D. But we can bypass the liver. What the liver does, it adds an OH group, hydroxyl group, to vitamin D to put it into the blood.
This is the calcifidiol
blood
storage form.
Yeah, absolutely.
Yeah.
But we can give that form by mouth.
Well, why on earth don't we do that every time someone gets an infection?
Yeah, because that part activated form, the calcifidiol, that is absorbed into the blood within about 2 hours. Whereas it will take up to 2 weeks for the raw form of vitamin D to become activated, or pod activated. The calcifidiol, it takes 2 hours.
So we have an immune optimizer that goes into the blood within 2 hours. And that is working one heck of a lot quicker than antibiotics,
it is,
which are going to take, even IV, they're going to take 4 or 8 hours to work.
Yeah.
And that's going to work. And then the cells can use that straight away. The white blood cells could use that essentially instantly.
Instantaneously, yeah.
So we could be getting the immune system really roaring into gear in my septic patients within 2 or 3 hours.
Yeah, absolutely.
And yet so what we have in emergency departments, we have something called the sepsis 6.
Yeah.
So we get them in, and you've got to tick them all off, and it's got to be done within an hour, rightly.
Yeah.
So first one is oxygen.
Yeah.
The next one is IV antibiotics.
Yeah.
The next one is checking lactate. I might be out of order. Checking lactate and hemoglobin.
Yeah.
Intravenous fluid resuscitation.
Yeah.
Checking the urine output. And I may have one other one I've forgotten. But really, we should change that from the sepsis 6 to the sepsis 7 then. We should be giving calcifediol.
I'm sure.
Because all of those things that we're doing, apart from giving the antibiotics, not really affecting the infection. It's just monitoring the body's response to the infection.
Yeah.
Antibiotics
won't work if the immunity is no good. We've got to have immunity. Antibiotics are very useful, obviously, very, very, very important. But the immunity system, the natural immunity in the body, is of vital importance, and we've got to make sure it's optimal, that it's working properly. And the thing that keeps it from working properly is vitamin D deficiency. Now, we could come on to, you mentioned coming to a hospital seriously ill. And the other thing is, one thing that makes you seriously ill is having an operation, quite honestly. A major operation means you're temporarily seriously ill.
Yep.
And you've got to get over that operation. And that requires defensive immunity as well. And it's been well worked out that post-operative complications are more common in people who are vitamin D deficient. So, preoperative check when you go into hospital, pre-op check should include a vitamin D level of the blood.
But it doesn't.
For a major operation.
I mean, why is it, It's so obvious.
It is indeed, yeah.
Well, why haven't the health authorities worked this out? I mean, it's...
You and I believe in nature.
The created
and we've
order.
got to believe in nature.
Yeah.
We've got to optimise our natural immunity.
Yeah.
And we know we're all vitamin D deficient. We know we work indoors, not in the fields. We know we have a lot of clothes cover. We know we've got a lot of cloud cover. We know that half our year is we don't produce vitamin D because it's winter. We know all these things. Let's put it all into action. There was a photograph in the newspaper last week. It was of a little Afro-Caribbean, Black African ethnic child. And it said he was to illustrate a finding that's come from the paediatricians that ethnic minority children have a much higher complication rate after they've had their appendix removed. They're slow to recover, more complications. Why is this? Is it something to do with racism? Well, it's glaringly obvious. It's glaring. We know very well that these children from ethnic minority backgrounds are born deficient in vitamin D. We know that
probably deficient when they were a fetus.
Yeah, absolutely, yeah. We know very well that vitamin D is essential for optimising immunity. And we know that post-operative complications are more common in people with defective immunity, and also in people who are vitamin D deficient. We know it all.
Let me see if I can work this one out. It's just so obvious.
It is indeed. We synthesise 7-dehydrocholesterol, 7-DHC in the skin. The sun converts it into vitamin D. But the problem is, when we get old, we don't produce the oil in the skin. Very old people are always deficient of vitamin D. It's inevitable because they've got dry skin. The skin is not producing adequate amounts of 7-DHC. And therefore, it doesn't matter how long they sit in the sun, they're not going to have adequate amounts of vitamin D. When we give them a supplement, they just need a normal supplement, a normal dose. Elderly people, people with pigmented skins, dark skins, all require the same amount of vitamin D as a supplement. But obese people require additional. They require more. But the amount required depends not on age or skin colour. It depends on body weight, effectively.
Got it. And of course, it's fat soluble. So if people had a lot of adiposity, a lot of fat cells, the vitamin D would simply just diffuse into those cells. That's simple physics, isn't it? And
it is indeed.
Would hide away and it's not there to be used. It comes from your skin, that's the vitamin D3.
Yeah.
What comes from a tablet, that's the D3, that goes to the liver.
Yeah.
How long does that activation process take?
Several days, should we say, up to perhaps a month before the high blood levels are achieved, before full conversion has taken place. It's a slow process. There's no reason for it to be fast, because ideally we're producing vitamin D every day. So it's just a daily top-up.
So you keep putting it one end of the pipeline, keeps coming out the other.
Yeah. If we're taking 3,000 or 4,000 units of vitamin D a day, and the blood level's the same, that means we are consuming 3,000 or 4,000 units per day.
Yeah.
We require that to keep us fit and healthy. If we are very deficient in vitamin D, and we take a single large dose of, say, 20,000 units, which is, generally speaking, a week's supply, it'll take a week for the blood level to come up to an ideal level.
And that takes us into the storage form.
Yeah, it does, yeah.
The calcifidiol.
Absolutely.
Storage form.
The storage is not in the fat cells. The storage is actually in the blood itself.
So it's just ready to go when we need it.
Yeah, ready to go. It's circulating, ready for action, in contact with all the cells of the body. So when they're triggered, there's an infection taking place, they pick up more and more vitamin D from the blood, and then they reprocess it and reactivate it ready for action.
How long does it take the cells to get the vitamin D working from taking it from the blood?
It's more or less instantaneous.
Right, so it's a week or so to get the vitamin D through the liver.
Yeah.
But once it's in the blood, it's banging, it's there.
Yeah, it is indeed.
Right.
Now, if we take it by mouth as a supplement, and from the skin, it's got to go through the liver, and that's the slow process.
Which takes time, yeah.
And if we're very deficient, but seriously ill, it's going to be a week or so before we get the vitamin D that we need into the immunity cells.
And we just get this all the time. Every shift on A&E, you'll get several patients in with sepsis, respiratory sepsis, urinary sepsis, or if not sepsis, severe infections.
Yeah.
So there's no point giving them high doses of vitamin D as soon as they come in.
No, the high dose side doesn't work. The high dose doesn't get action any quicker. It's got to go through the liver. That's the hold-up. So I think that the problem at the moment, why there's been a lot of additional illness, and there is a lot of illness, no question about it. The ambulances aren't queuing up at the hospitals for no reason at all. It's because our immunity is damaged, and I think we need vitamin D in a big way at the present time. It's a public health imperative, really, but it's not happening.
And there's a lot of people watching this video feel a bit run down, a little bit tired. It's not spring yet. We're still at the end of winter.
Yeah.
And, most people like me have had 1 or 2 viral infections over the course of the winter.
Oh.
Those viral infections are going to use up my vitamin D. So I'd have much lower levels of vitamin D after a couple of viral infections, and it can be really quite low.
Yeah.
And that can give rise to sort of physical symptoms. I mean, if you are very low on vitamin D, how might that make you feel? I mean, is the tiredness, the heaviness, are they features of it?
I'm not sure, quite honestly. I wouldn't say so. Might be true, but I'd really just go for the infections and the specific diseases rather than how you feel.
Right.
People say, how can I recognise that I'm deficient in vitamin D? And the answer is, well, you have a blood test.
Chronic lack of vitamin D is an etiological factor in dementia and potentially other neurological diseases.
Yeah.
Have you got any thoughts about the connection between vitamin D and neurological diseases?
Well, I think it's true to say the strongest one is multiple sclerosis. But that goes back to birth, because a baby born in the spring will have an increased risk of developing multiple sclerosis in adult life than a baby born in the autumn. Now, the autumn birth means the mother was pregnant during the summer and that she was there getting vitamin D to pass on to the baby in the uterus. And so the baby born in the autumn has a biological advantage in several different ways. Whereas the baby born in the spring, the mother was pregnant in the last 3 or 4 months of pregnancy during the winter time with no vitamin D. Now, to my mind, no baby should be born in this country or anywhere deficient in vitamin D. Because I think every mother, every woman who goes to the antenatal clinic should have a blood level of vitamin D check there and then.
But this isn't done.
It's not done, no. There's been the Sure Start project, which we had in Blackburn, which I was part of. And with that, we gave mothers, expectant mothers, vitamin D during pregnancy. But the Sure Start project has been cancelled. It's a central project. It's been cancelled, unfortunately, by government. So that doesn't happen now. But really, we should be checking the pregnant women, protecting them. There's a lot of evidence that vitamin D deficiency is related to eclampsia. Oh, what do they call it? PET now?
Yeah,
pre-eclamptic toxemia, pregnancy.
The high blood pressure, the proteinuria, the edema.
That's all, yeah, indeed. So a more successful pregnancy requires vitamin D and the baby after it.
Amazing, really. So we've got 3 things there: the health of the mother, perhaps optimising fetal development, and making sure the baby's vitamin D level is topped up when it's born. So as soon as a baby's born, it's going to be assaulted left, right and centre from the milieu of viruses and bacteria.
That's right. We hear about rickets in young children. That should not happen. It particularly occurs in the children of Black African and South Asian ethnicity, because their mothers, we know very well, are going to be deficient of vitamin D. People with dark skins do not produce enough vitamin D in the environment of the UK, where we're living closer to the North Pole than to the equator. At least these poor women should be checked. These women should be checked. The ethnic minority women should be targeted in particular, but they're not being, I'm afraid to say.
But even I'm pretty white, as you can see, and last summer I got quite a bit of sun at the allotment. So for about 5 or 6 months last summer I didn't take any vitamin D, and I actually managed to persuade my GP to check the levels. At the end of, it would be about September, the very end of summer, and I was pretty confident it would be topped up because I had a lot of sun exposure. And it was only about 75 nanomoles per litre. Still didn't have anywhere near optimum levels of vitamin D. I was very disappointed, and I've certainly gone back onto the supplements now.
It's a hormone, without any shadow of doubt. It's a hormone that's produced in the skin. We produce an oil in the skin called 7-dehydrocholesterol, and DHC, we call it 7-DHC, and the sun converts that into vitamin D, which enters our body, activated partially in the liver, and then activated fully in the cells. It is a hormone. The point is that it's not just humankind that produces vitamin D from 7-DHC. It starts off with plankton, and they produce 7-DHC, the oil, as a sunscreen. And it absorbs sunlight energy, it's converted into vitamin D, but the plankton have no use for vitamin D. Firstly, they don't have a skeleton, so they don't need it for bone, and they have a very primitive immune system. Plankton live close to the surface of the sea, so they are actually prone to UV damage. But the 7-DHC absorbs the UV energy to a large extent, and vitamin D is the waste product. But plankton also tend to sink during the daytime and rise to the surface during the night time, which again protects them. Now, fish don't produce vitamin D either, because they have scales and they live deep in the sea. But fish eat plankton. It's the start of the food chain, and we eat fish.
Do fish need vitamin D for their physiology as well, then?
Yes, they will do. Yeah. Yeah, certainly.
So
well, the bony fish need it for the bones, but all fish will need it for the immunity. But land animals also produce vitamin D as a hormone in the skin. And we eat land animals, and we take vitamin D from meat. But our vitamin D supplements come from sheep, because sheep produce vitamin D in the skin. When the fleece is taken off in the summer, when it's too hot for them, the oil of the wool contains vitamin D and it's extracted. And when we have vitamin D supplements, it comes from the sheep's hormone. We call it a vitamin then, but we're not taking in a vitamin, we're taking a hormone from the sheep. It's like if we're short of thyroid, if we have an underactive thyroid, we take thyroxine tablets. Well, the thyroxine comes from animals. The animals produce the thyroxine, and we take the thyroxine from the thyroid extract from the animals. It's not as primitive as that these days, but nevertheless the principle is all the same.
It's the titration, isn't it?
It is a titration.
Start off on 3,000.
Yeah.
For most people, I think it would be fair that we probably need, I'm sure I need about 8,000 a day personally for my body weight.
Well, I think that's right. So you could argue that someone weighs 120 kilograms for in excess of your weight might need 12,000 units a day. Yeah. But again, it's a matter of measuring it. With body weight, by the way, the obese people do not have good blood levels of vitamin D. The vitamin D they produce in the skin tends to be soaked into the fat cells of the body, and it doesn't seem to come out again. So if you take an obese person and a non-obese person, expose them both to the same amount of sunlight or UV light, the obese person will produce perhaps only half the amount of vitamin D as measured in the blood than the non-obese person. So obese people do require more vitamin D. There's no easy measure of immunity. In fact, the blood level of vitamin D is a reasonable surrogate for measuring immunity, because we know if people have high levels of vitamin D in the blood, good levels, they don't get infections like flu or COVID. And if they have low levels of vitamin D, they do get a lot of COVID, flu, and also a lot of other diseases as well. So immunity is best measured actually by vitamin D. Anyway, so we start off and we measure the response, and we get there. And somehow it's going to be about 6,000 units a day. That seems reasonable, and it is perfectly safe.
So it's quite possible that you could give you and me 6,000 units of vitamin D a day each, and for genetic reasons, for microbiome reasons, for maybe 1,000 reasons we don't understand. I don't understand certainly. We could end up with really quite different levels. There's a difference in response.
Indeed.
Now, what I find really curious here is that the vitamin D levels that are advised were basically worked out to prevent rickets back in the 1920s.
Yes, that's right.
And we've learned all these new functions and no one's bothered
no, indeed.
to update the requirement. It just seems utterly bizarre.
Well, it's now possible to measure the mass of vitamin D. And 1 unit weighs 25 billionths of a gram. Now, it's not very much. So what you find out, that when you get capsules of vitamin D, no matter what the dose of vitamin D is, they all look the same. And people can't get their minds around this for obvious reasons.
Actually tiny.
But 99% of the content of vitamin D capsule is olive oil. There's a tiny bit of vitamin D by mass and by volume, because it's an oil. So
why can't we test immunity by doing a differential? I'm sure you've ordered differential white cell counts about 10,000 times.
Yes, that's right. But that's
looking at the different types of white blood cell.
Yeah, that's right. It still doesn't quite work out.
Could there be a situation where you had the right number of white blood cells, the right number of lymphocytes, and the right number of neutrophils, but because you haven't got enough vitamin D, they could be physically present, but physiologically suboptimal in their physiological activity?
That's the problem. It's the function. not the structure. The T lymphocytes are critical, and the T lymphocytes are very dependent on vitamin D for their activation, but also very badly damaged in AIDS. And AIDS, of course, leads to infections, malignancies, because immunity is suppressed. And it gives a very good example, actually, of how immunity is suppressed. When it is suppressed, it leads to a lot of illnesses, strange infections, malignancies in AIDS, heart disease in AIDS, dementia in AIDS. A lot of things came out in AIDS which told us the importance of immunity, and in particular T-cell function.
How much vitamin D should I take? Because we know that vitamin D is essential for immunity.
Yes,
that
indeed.
debate is finished.
Yeah.
We know it's essential for numerous other aspects of health.
Yeah.
Reducing chances of cancer, heart disease, probably type 1 diabetes, whole range of things that we've covered. But how much should I take?
It's a bit like diabetes, actually. Someone has diabetes, they say, well, how much insulin should I take? And the answer is, you take enough for you as a person. The question is, what are we trying to do? Well, firstly, we're trying to prevent things like rickets. That requires a tiny, tiny amount of vitamin D. But the other thing is immunity, which requires a lot more vitamin D, quite honestly. Probably 1,000 times more. So, sometimes recommended we should take 400 units of vitamin D. Well, 400, it might prevent a child from developing rickets, but it's not going to do anything for immunity. For that would require at least 10 times as much. Well, we're trying to achieve a good blood level of vitamin D. And the blood level we require is between 100 and 150, actually about 150 nanomoles per litre. That's the objective. And if we look at the experience from COVID-19, we find out that people who've got over 100 nanograms per mil blood level, they don't come to any harm from COVID. When people take vitamin D, ideally they should have the blood level checked. It's like with diabetes, you get your blood tests. It's like with hypertension, you get your blood pressure measured. You're trying to achieve a target, and that's what we're trying to do. The amount of vitamin D an individual requires to achieve a target level of over 100 nanomoles per litre, that varies from person to person, quite honestly. But a good starting point is to say, well, what is a unit of vitamin D? Now, a unit of vitamin D is like a unit of insulin. They were both discovered at about the same time, 100 years ago. It was not possible to weigh them, to develop a mass measurement. It was only possible to have a biological measurement. And the biological measurement of vitamin D is that 1 unit is the daily requirement of a 10-gram mouse. So, when you say how much do we need, let's start off with the 10-gram mouse, 1 unit. Now, 1 unit of per 10 grams means that for a human with a body weight of 60 kilograms would require 6,000 units. We'll say, okay, if 6,000 units sounds about right for 60 kilograms, let's make a start on 3,000 units.
Which is very conservative.
It is conservative. The Standing Advisory Committee on Nutrition, SACN, was advising 400 units, but does admit that 4,000 units is perhaps the maximum that should be taken. What evidence for that? I don't know. Let's say we start on 3,000 units a day and then get your blood tested after 6 months, say. See what it is. And if it's not up to 100, you increase the dose. Like you do with insulin in diabetes, like you do with your treatment of hypertension. You judge the dose by the response it's had.